This is the coarctation segment. Here it is very discrete. So in adults, the commonest type of COA is a discrete COA. Here just the obstruction. While the rest of this is the isthmus. This is the arch. So the diameter of the ascending aorta, or usually the comparison point is the aorta at the level of diaphragm. So here the diameters are maintained and there is a discrete or a focal coarctation of aorta. You can see it is just next to the PDA, post left subclavian artery. So in immediate newborn period, if babies are discharged after checking lower limb pulse and saturation, it is found to be a very important screening test for COA. When the lower limb saturation is less than 95% or bilateral lower limb pulses weaker than the upper limb pulses, or the systolic blood pressure in the lower limbs are 20 millimeters of mercury lower than the upper limb BP, then it is diagnostic of coarctation. It is a very important screening test in children. Usually patients with COA will have a very wider ductus. So that is supporting the flow theory of Rudolph. That is, the flow is preferred across the ductus rather than the aorta. So 3 different types of COA. Like I said earlier, this is the commonest type which is present in adults, also called as discrete COA, which is juxtaductal post left subclavian artery. While the second type is discrete COA, not only that, there is hypoplasia of the isthmus. Isthmus is the meeting point of the arch of aorta. Arch ends at the left subclavian artery and the descending aorta. So there is isthmus hypoplasia, which you can see is not here because the diameter is tapering from here to here. And here there is one more abnormality. We will see about it later. The third type is the commonest type in children, that is neonate or fetal life, which is not just discrete COA and isthmus hypoplasia, but arch hypoplasia, where the diameter starts tapering from the ascending aorta through the carotid subclavian artery into the COA. So that is called arch hypoplasia. 3 common types. The adult common type is a discrete COA. The second type is a isthmus hypoplasia. The third type, which is the commonest type found in neonates or fetal scan, is the hypoplasia of the arch, isthmus and the COA. Here we can see the 3 different sites of COA. Here it is pre-subclavian, also called as preductal. This is the commonest type, that is the juxtaductal. There is another type which is a very rare type, less than 3%, where there is anomalous right subclavian artery originating from the postductal site. So this is the anomalous artery, like a dysphagia lusoria, which comes after the ductus, after the coarctation site. So if you see, this is a common fallacy in palpating all limb pulses or measuring BP of all the limbs. The right subclavian artery is a postductal artery, so BP will be lower in the right limb, while it is relatively normal in the left upper limb, while the left and the right lower limb will have lower BP. So this discrepancy, the first diagnosis will be aortoarteritis, which is a scattered involvement of the arteries rather than COA, but this is a diagnostic fallacy because of the aberrant origin of right subclavian artery post coarctation segment. Here also there is a fallacy in that the left subclavian originates after the coarctation segment. 2 things to remember in this type is that the left upper limb also will have a lower BP. The only normal BP limb is the right upper limb, while the left upper limb, both the lower limbs will have lower BP. That is obvious. While there is a syndrome called a subclavian steal syndrome, which is common only in this type of COA. That is, the left subclavian artery steals the blood from the vertebral artery during exercise involving the left hand. Like raising the hand above the head can result in vertebral steal, which can be symptomatic, that is with vertigo or giddiness. So these are the 3 sites: juxtaductal, preductal COA and the postductal COA. This is one very rare type. Less than 3% of CoA segments will have anomalous right subclavian artery originating from beyond the coarctation segment. But this does not cause compression of trachea or esophagus, unlike the